to diagnose diseases and we have been trained to treat diseases. But somehow, somewhere, we often forget that the center of everything is the patient. We are actually treating the diseases, and usually, somehow, all of us end up practicing a disease-centered approach, where the priority is to identify the disease and to cure the disease. But the person who occupies the center stage, the patient, that is often neglected, and the patient comfort and the patient perceptions, patient perspectives sometimes actually take a back seat. And palliative care is a diametrical shift from the disease-centric approach, where actually the priorities and the preferences of the patient are given utmost priority. And palliative care is done in scenarios where actually there is a life-threatening disease for which no cure is there, and the emphasis is on the patient well-being. We have to prevent the suffering of the patient, and we have to deal with a different set of problems that are associated with the disease progression there. Now, like there are a lot of confusing terms when it comes to palliative care, end-of-life care, hospice care, and all. So, Dr. Kiran Mai, can you elaborate on what are the different aspects of palliative care?
Morning, everybody. Yeah, Priyambada, actually, you have already defined what exactly is the palliative care by giving the WHO definition. So, as we understand, the palliative care is defined as the comprehensive management of the physical, psychological, social, and spiritual existential needs of the patient in a serious illness. But if you take what exactly is kidney palliative care, then we should say the improving the quality of life of the patients with chronic kidney disease, not only the patients and even the families. You are offering a qualitative solutions to the patient's different problems, not only the conservative management of the symptoms, but also if needed the therapies like which will be extending the life of the patients like dialysis also will be offered. So that is how you define it's a kidney palliative care. But what is exactly the end-of-life care? So the end-of-life care is applied to those patients whose lifespan is expected to be less than 6 months and who already have foregone the curative therapies and taken to the restorative therapies. So that care will be offered to those patients. But you have another term also, the terminal care. So this care is actually applied to those patients. It will be provided to those patients who will be ending their life with dignity.
So, as Madam rightly told, care is a continuum, and each and every aspect we are dealing. For example, when it's terminal care, that's basically relief of suffering, and the palliative care doesn't really end there. And there is a component of bereavement care which actually you are offering to the families. The family and the patient is taken as a unit when we come to palliative care. And let us move on to a clinical scenario. There's an 81-year-old male patient who has type 2 diabetes for around 25 years, and he is a known case of coronary artery disease. He had suffered 2 MIs in the past. That was somewhere around the age of 70s, and he was diagnosed to have a triple vessel disease, but he and the treating team had a discussion, and eventually it was decided to put 2 drug-eluting stents in the left anterior descending and right circumflex, and around a year back he had a CVA, from which he had made a partial recovery and he was able to work, but unfortunately sometime later he had a fall and suffered a fracture neck of femur, and it was decided to manage conservatively. And he is presenting to the emergency department with some breathlessness, and on evaluation he is found to have an end-stage kidney disease. Now I would like each of the panelists to tell me what would be your next plan of management if that patient comes to you. Let us start with Dr. Shivram.
Here, an 81-year-old male with almost multiple complaints with irreversible problem is end-stage renal disease. The rest of all can be treated with conservatively, but whenever patient comes in these complaints, we have to assess the overall any reversibility of factors in this patient, and based on the setup also it is very important.
Yeah, there is no reversibility. It's an established case of ESKD, and the GFR is around 7 or 8 ml. What would have been? What would you advise as a treating
Ideally, he
physician?
requires hemodialysis or peritoneal dialysis or transplant.
Yeah.
Transplant is out of question in this age. And then we have to think of hemodialysis and peritoneal dialysis. If already he has any access and all, if it is, we can discuss with patient's attendants and we can try for hemodialysis. And if at attendants and anybody taking care in the house, if there is any option, CAPD also can be tried. But it depends on financial aspect of the patient also. And whenever this type of patient comes to this government hospital and all, I work in a government setup, we counsel the patient's attendants regarding the issue. And even though we start hemodialysis, attendants has to be there to get the patient from home to the hospital also. That also very important. Not only starting hemodialysis and sending home. And also CAPD also somebody has to do in the house. Very few people are interested in doing, family members. These all things has to be counseled properly before
It's
taking
actually not
decision.
not as clear as it appears, okay? Because there are so many things which probably you don't know. And Dr. Jaimina, what would have been your decision in this scenario?
The first thing what we have to do is to stabilize the patient, treat his suffering. The main problem is his breathlessness, so we have to address that first. It can be either through conservative management, by medical management, if he's not improving. Session of hemodialysis would also help. But it is not with the intention of a long-term hemodialysis or treat to target like weekly thrice or something like that. I would in fact actually counsel the relatives, patient, to relieve suffering, you can actually offer him hemodialysis and what should be the plan
Yeah,
next.
we will discuss over that. And Jayalakshmi ma'am, what would have been, do you agree with both of them or would you like to have a different plan of action?
Yeah, basically, if there are any reversible factors, I would like to do a hemodialysis few sessions. But then if we know it is not reversible, I will find out the situation of the patient's attenders, whether they're financially okay to do a home hemodialysis. If that is possible, we can advise a home hemodialysis wherein we can, if we have mobile units, you can send to the house and have some hemodialysis done for a while. But then how long it will go, we cannot say because it's already an ESKD patient. So I will note the idea of palliative care in these patients when I'm unable to give optimal dialysis care.
Yeah. Yes, Kiranmai ma'am, any difference of opinion or anything you would like to add in this situation?
Actually, it should be see the balance, whether the potential benefit of the curative therapies vis-a-vis the potential burdens of this therapy to this particular patients. Actually, it's better to discuss with the caretakers, and if the patient can give his consent also, the restricted prognosis has to be discussed with him, and the main emphasis or thrust is on the restoring the functional capacity or the quality of life only.
And Maitri, like anything to add from your side?
My first aim would be to save the patient. So if the patient has come in with breathlessness, I would definitely initiate the patient on dialysis and stabilize the patient. That would be the first aim. Later on, maybe discuss about other parameters and try to find out the functionality of the patient and dig in deeper.
Yeah, so basically, as I told, this is not a very clear-cut situation. So when somebody comes in the emergency department like this, probably we don't really have much choices. Manage conservatively with some diuretics and other supportive care, and if the patient doesn't improve, obviously this is a situation where actually we would end up taking the patient for hemodialysis because we need to alleviate the sufferings. But the important question is what next after stabilization and if there is no reversibility. So that is a sort of gray zone, and obviously everybody agrees that transplant is not going to be the choice here. So now I would like to ask a question to Jayalakshmi ma'am. So first, what is the need of palliative care in nephrology? Like, is it just something that only applies in cancer and some incurable diseases like that? And second thing is, a patient like this, the same patient whom we have discussed, if we put him on dialysis, how he is going to perform in the long term?
Actually, nephrology is an expanding field, and we have a lot of patients who need nephrology care. And as the life expectancy of the general population increases, more so with the nephrology population also, because we tend to give a lot of supportive care and patient tends to live longer and longer. And we get a lot of patients with multiple comorbidities. So we come to a position, a point of time to decide whether we need nephrology palliative care. The answer is yes, because we have a huge population who needs nephrology care, and a significant number of them have multiple comorbidities. They are quite older, senior generation of population, and a lot of problems, logistic problems, socio-cultural issues, where regular dialysis at the center becomes very difficult. For example, I'll answer the second question, where the quality of life in the elderly, actually as the age advances, the quality of life in the elderly on dialysis starts declining. The age expectancy also declines, and the quality of life is also poorer and poorer, because most of the time that is saved, the life that is saved due to dialysis, is spent on dialysis and dialysis complications and hospitalizations. So ultimately, the quality life of the patient is not gained. So many of them may benefit with palliative care.
So basically, this is some data looking into how actually the older individuals benefit from dialysis. So the average life expectancy for people who start on dialysis at the age of 80 is around 1.3 years, and the interquartile ranges might vary from 4 months to 3 years. And as we move closer to 90 plus, most of them live for around 6 months after initiating into dialysis. Now again, the observational data has shown that people who opt for maximum conservative management, like people who refuse dialysis voluntarily, they might live for around 12 months after that decision to refuse dialysis. And on the other side, people who decide to opt for hemodialysis, they might end up living for around 30 to 36 months. But the problem is, around 12 months of that 30 or 36 months, they are going to live. That 12 months they spend in and around hospital. So most of that time it will be with hospitalizations required to dialysis, hospitalizations because of intercurrent illnesses related to dialysis related complications and all. Now the major question is it really worth living a life that is attached to a machine, and that is actually half of their whatever remaining life in hospital? That is a question that the individual has to decide on. And again, there has been observational data on how the quality of life deteriorates as the patient approaches end-stage kidney disease. Now you can see that in elderly, as actually they approach towards end-stage kidney disease, there is a gradual decline in the quality of life parameters. But again, here we have to understand that most of these studies use SF36, and it actually splits into a mental composite score and a physical composite score. But quality of life sometimes actually is a parameter that just cannot be captured into a number. And it has been shown that once they initiate on dialysis, there is a gradual improvement in quality of life. But if you see, look at the graph down, there is a steady increase in mortality also. So in the best case scenario, this is what we expect. Like there might be a somewhat improvement in life, but it could be on other extremes also. It could be the worse also. But again, I would keep to emphasis that you just cannot actually deny, or you just cannot discuss palliative care with someone just because of the fact that they are 80 plus or 90 plus. So in an African country where actually people are toiling for their day-to-day life, 50 is considered as elderly. Whereas actually in a developed country, 65 or 70 is not considered as elderly. So age is not going to be the only factor. Now, an elderly person comes to you with a little bit of comorbidities, and of course it is actually inhuman to deny dialysis just because the person is old. But the problem is not every elderly is comparable. Some of them might be in a good condition, some of them might be worse. So is there any way to assess for a given elderly patient how they are going to perform on dialysis? And is there any way to identify who would deteriorate on dialysis and who would benefit from dialysis? Maitri, can you take up this question?
At the outset, I would like to thank the organizers for making me a part of this session. Yeah, like patients who are elderly and who are in end-stage kidney disease requiring dialysis, they would want to know their life expectancy and their prognosis. Just like any patient with cancer who is on chemotherapy would like to know their life expectancy, it is the same with patients who are on end-stage kidney disease, elderly. they would want to know their prognosis. So we as nephrologists, maybe we don't have so much of time to tell them or, to appraise them about the situation and the prognosis. Interestingly, one study also showed that 50% of the patients who were on dialysis, they said that they were put on dialysis purely based on the recommendation of the nephrologist. And 60% of them who were on dialysis, they said that they regretted being on dialysis. They were never even questioned. So the bottom line is that we as nephrologists are not informing them about other modalities of therapy apart from dialysis. There might be various reasons, lack of infrastructure, time, etc., etc. But there is a simple way. There are scoring systems. There is a simple questionnaire which we could use on our OPD basis or at bedside as well. So the two most validated scoring systems are from, one is from France, that is a RENE registry, and another one is from America, that is from the USRDS registry. So when we look at the RENE registry, it is Renal Epidemiology Information Network. This is from the French population, French cohort. So you can see that there are 8 clinical parameters along with serum albumin. So based on this, there is a scoring, and based on the scoring, the elderly patients who are more than 75 years of age on dialysis, they are stratified as high risk, intermediate risk, and low risk. So this risk gives the probability of mortality at the first 3 months of initiation of dialysis. So if you look at low risk, the probability is very less, probably 0 to 20%. So these patients may not require too much of efforts or too much of intervention. All they require is nephrologist care and dialysis technician and nursing staff. If you think that the patient is robust, you might even go in and transplant that patient, even if he is more than 75 years of age, if he's got good functional capacity. Now, if you look at the high risk category, these are the ones whom we need to offer palliative care, who would require complete comprehensive geriatric assessment, and the help of geriatrician would be very valuable in this scenario, because as you said, it is multidimensional, and we need a multidisciplinary team to look into, where we explore the social factors, we explore the spiritual area, we look at the psychological dimension, cognitive dimension, behavioral dimension. So everything we have to consider, and then give option for the patient. The patient might choose for palliative care, or he might even choose for adjusted dialysis. Adjusted dialysis is probably we could give a trial of dialysis for a patient for a month and see if the patient is doing well or not. If he's not doing well, then probably we can stop the dialysis. If not, we can tailor the prescription of the dialysis based on the needs of the patient. We could just offer dialysis when the patient is in volume overload, or just to maintain electrolyte balance. Even nurse-assisted peritoneal dialysis also helps in keeping the patient symptom-free. Now, looking at the USRDS data, so this is again from the American population, and this is derived from the registry. So this has the following components: age, serum albumin. Does he need assistance in daily living? Does the patient live in a nursing home? Has cancer? Hospitalized for more than once or more than a month in the last year? Or has had heart failure? So for example, if you see a patient who's between 85 and 89 years of age, then the score is 2, and serum albumin level is less than 3.5. The score is 1, so the total score is 3. So if you look at the graph, at the level of 3, the probability of death at 3 months is around 12%, and the probability of death at 6 months is around 20%. So with the help of these scoring systems, it helps the patient's family to take a rational and well-informed decision, and to create a plan of action for their future personal life as well as the health-related life of the patient.
So now, if you have actually seen the RENE, the scoring system developed from the RENE registry and the USRDS, you can see most of the parameters are actually somewhat similar, but the point allocation to certain things is quite dissimilar. For example, the RENE registry, they have given complete dependence 9 points, which actually makes it the worst prognostic marker. Now coming to the USRDS data, the patient assistance needs assistance in daily living, that's just given 1 point. It is basically like other parameters like hypoalbuminemia or heart failure. So the problem with this scoring system is, it is good in the cohort in which it is derived. But the problem is it might not actually applicable in a scenario where the physical circumstances are somewhat different. So the external validity is going to be always a problem. So it is very clear that in an Indian setup where actually things work in a quite different way, we might have limitations in using any of this scoring system. But what needs to be kept in mind is the functional status of the patient acquires quite a lot of importance. For example, someone who is bedridden, who actually needs assistance for every single activity for his living, probably is a candidate who is not going to perform well on any form of dialysis modality. Whereas on the other side, the same patient whom he has discussed, I just told fracture neck of femur. I didn't actually mean that he is bedridden or not. It might be actually like a hairline fracture which is managed conservatively and still the patient might be ambulant. That actually changes quite a lot of things. For example, if he is bedridden, probably you will have to approach him in a different way, and if the patient is still able to carry out his daily activities, your decisions are going to be different. Now, the same patient on physical examination in the emergency department, it is noticed that he has got a cardiac failure with an ejection fraction of 20%. Now, Dr. Shivaram, does this information changes anything for the patient in your decision line?
If already patient has a chronic kidney disease and most of the patients have cardiac disease, this ejection fraction 20% means he has severe cardiac disease, maybe it is ICMP or DCMP. It will, this is very strong prognostic factor, and you can try to manage conservatively with the diuretics, oxygen support. If it is controllable with the oxygen support, we have to take care consultation with the cardiologist, and we have to prognosticate the patient, attendance and patient. Then we have to go for next management.
Yeah, so basically we stabilize the patient, so that day we were able to save the day without dialysis. Yes. Okay, but still after 2 weeks they come for a review and the serum creatinine is still around 12 milligram. Patient is relatively asymptomatic on whatever medications you have given. So now actually at this point, would you reconsider any of the options you have given? Like you still the hemodialysis is open, peritoneal dialysis is open, maximum conservative management also is still open. So of which, as a physician, what would you prefer?
If his cardiac condition is relatively stable and manageable with the conservatively, we can think of managing ESRD also in this patient, like the chronic CAPD with the chronic ambulatory
you love for
dialysis.
CAPD, so yes. That's a very good suggestion. Yes, and again, actually, I would like to, I know that this is a situation where we will have difference of opinion. There is no correct answer here. It's actually the individual perspective and the patient-related parameters that is going to guide you. So, Dr. Jayamina, in this scenario, how you are going to, what would be your decision?
Basically, the decision depends upon multiple factors. Basically, the amount of interest of the caregivers, whether the caregiver can take him to the hospital for hemodialysis, or the frailty index of the patient as such, whether the patient is bedridden, hardly could take care of himself, he is dependent on others for his day-to-day activities, or the interest of the patient. The patient says, I want to stay at home, I don't want to go to the hospital. I don't want a thrice weekly hemodialysis. So I would better continue with a peritoneal dialysis. All these things should be taken into consideration before a decision is being made. So basically, palliative care is a patient caregiver centered approach, then a clinician to patient approach. I might be interested in doing a hemodialysis for the patient, but that might not be the same interest the patient has in his future health plans.
So any of the other panelists, would you like to add anything? I think actually they have covered most of the things. Would you like to add anything new, which actually any other aspect that Dr. Shivaram and Dr. Jayamina has not covered?
Basically the shared decision making and the caregivers, how she can manage, he or she can manage the patient at home will decide on the CAPD. In which situation the patient lives, whether they can have a sterile room or a clean room to do the CAPD. If all that is possible, it's always better to go in for a CAPD, because with dialysis, some of the cardiac function can also improve and the patient can have a better quality of life. Yeah. If that is possible, we would go for that.
Yeah. So what we need to keep in mind is in this scenario, There are no like hard and fast answers. There's no correct answer or there's no wrong answer. It all depends on the patient is actually the center here. Patient occupies the center stage here, and it is actually the patient's choice. And unfortunately in India, we always discuss the prognosis with the relatives. But we have to understand that every person has autonomy over his life. It is his or her choice how to live and how to die, and the mode of death, like actually whether to go for dialysis or whether to go for maximum conservative management. It is a misconception that actually patients might not actually take things, patient might get actually afraid by the things. The only thing is you need to be gentle, you have to break the news in a somewhat acceptable way, which is not really shocking to the patient. So rather than discussing with the relative, this is the time where actually we should have a combined discussion where actually we should give utmost preference to the patient's priorities. There might be, you might have encountered a situation in which the patient doesn't want dialysis and the children will be insisting on dialysis. So this is a time where actually we need to sit down and talk, and as a physician, it is our prime responsibility that we should honor the patient's decision over and above anything. Now, what would be the, let us say, you have this gut feeling that probably this patient is not going to do well on dialysis, okay? We might actually tend to approach the problem in different ways, okay? Somebody would actually put the patient on dialysis, have a trial of dialysis, reassess after 2 months. But what I would ask Dr. Jaimina is, what is the best time to discuss palliative care? Would you put the patient on dialysis for some time, allow him to deteriorate so that the bystander is convinced or the patient is convinced, or would you like to have an open discussion right from the beginning?
The palliative care discussion should actually begin as soon as chronic kidney disease is being diagnosed. Like the life expectancy of the patient decreases as soon as he's being diagnosed with a chronic ailment. So the discussion regarding what should be the future prospects should be done as early as possible. Both the patient and the relatives and caregivers should be actually sensitized regarding the future plans. They should have an advanced care plan. What should be done in future. That is, it should be a patient-centered and a caregiver-centered approach. And it actually involves multiple stakeholders like dietitian, nurse, social worker. Everyone is actually involved in advanced care planning. And it should be individually tailored. It should be actually different for different people because it depends upon their cultural background, educational background, financial background. Everything should be taken into a consideration while planning for palliative care options in end-stage kidney disease.
So, the best time to discuss palliative care is as early as actually making the diagnosis, and provided you feel that the patient is in a gray zone. And this is actually a collective effort. You are not the only person who is going to be involved. There are multiple stakeholders, and mutual trust is very important. Trust between the patient and the physician is extremely important, because this is not a one-man show or a one-woman show. That is what we need to understand. And let us move into a little bit deeper into the palliative care. There are two aspects of palliative care when it comes to nephrology. One is the primary palliative care and the other one is the specialty palliative care. Kiranmai ma'am, can you elaborate on these concepts of primary palliative care and specialty palliative care?
Yes. So as we know, the palliative care as defined, we know the care of the patients in all aspects. But what is actually kidney specific palliative care, how different is this is, we should understand that whenever you encounter a patient with the kidney disease, either this is chronic kidney disease or AKA, you should understand the patient, whether the patient has other comorbidities or the answer to the surprise question. So what do you get? Are you surprised if the patient is going to, you are not going to see the patient in the next 12 months or so? If the answer is yes, then you plan accordingly. See, advanced care planning is a dynamic process. Initially, you will be taking the confidence of all stakeholders, and the first and foremost is the patient itself. He himself, whether he should be included in the decision making and who else should be included in the decision making should be discussed with the patient. And you should actually discuss the restrictive prognosis with the patient himself. This, by doing this, you are doing a lot of favor to the patients, because you are giving the opportunity to the patient to plan everything. So whether he has to go for the treatment or palliative treatment or prolonging the life treatments, or how flexibly he has to plan his life, whether he has to plan a dialysis schedule, or he want to spend a life with the grandchildren, or how to take his schedule to, in order to spend life with his loved ones. Not only this, they may have to plan how they want to exit with the dignity also. So the dynamic process involves early in the phase of planning, the stabilizing therapies and life prolonging therapies like dialysis, and you will be actually concentrating early in the course of the care, how to stabilize him and how to provide dialysis options. And later on in the life, when he moves into the later part of the life, then he will be actually planning of the end of the life care and the terminal care himself. So you are offering a holistic approach to the patient and his caregivers, taking in the consideration all the family backgrounds, their core values and beliefs, religious beliefs, and they will plan according with the other clinical staff, nursing staff, and the social worker, as Madam already expressed.
So basically primary care is basically dealing with the day-to-day problems we come across, whereas kidney specific palliative care is basically, it involves a lot of discussions, planning and brainstorming, and that is where actually the team comes into picture. Now this question goes to Maitri. Who are the essential workforce needed? Like, we know that India is a country where we have a huge demand, huge number of patients, and resources are limited. So basically Western models are not going to work in our situation. So in a situation where there is a demand supply mismatch, how are you going to create a palliative care team?
Answering your first question.
In the context of the specialty palliative care, because the primary palliative care, probably a trained physician, need not be a nephrologist, can actually take care of that, but kidney specific palliative care is entirely in the nephrologist domain.
So answering your first question, the main goal of the multidisciplinary team is one, it is to add quality to the life of whatever years the patient is going to live. So from the patient's point of view, first we have to formulate the team, the patient himself, the patient's caregivers, they may be non-family caregivers, but they need to be included as well, the patient's immediate family members. And if the patient has any, he's sane enough to assign a legal agent, we may have to include him as well. And from healthcare point of view, there are multiple people. The geriatrician would be very important, of course, a nephrologist. And then we have palliative care specialist, we have the nursing staff, medical social worker. We have to look at all the dimensions, spiritual, cultural, psychological, not just the physical aspect. So if there is any clergyman or a member from the religious community whom the patient wants to be present, we may have to include them as well. So the first idea is to first develop a good rapport between the patient and the patient's family. I mean, between the doctor, the patient and the patient's family, because you have to take them into your confidence when you're discussing palliative care. So we might as well make use of a family physician if the patient is regularly going to a family physician. He would trust what the family physician says more than what he would trust, more than he would trust you, because he would have met you hardly a few times in his lifetime. The second thing is to completely, thoroughly tell the patient about explain the patient about the diagnosis of the disease, the prognosis and the treatment options. That when we say treatment options, we have to be very clear about the complications and the cost of the treatment as well. So the complications and the cost of dialysis, the complications and the cost of conservative management. So this will help in shared decision making. But when you look at our country and resource limited situation like just what you mentioned, I would prefer, like I work in a government setup. So I would at least prefer to have a nursing staff who's trained in palliative care and a medical social worker who's trained in palliative care. And I would not go around giving an option of palliative care for all the patients who are going into dialysis. I would target and direct our resources towards those patients who would actually benefit from palliative care, like someone who's elderly, more than 75 years of age, multiple comorbidities, moribund, bedridden, has multiple fractures, heavily dementiated. So those kinds of, or severe hypotension. So those kinds of the patients whom we would like to direct our resources towards.
So the other person whom actually we often neglect. So when we come to palliative care, the entire focus is on the patient. But the other important person in the loop whom we actually should not forget is the caregiver. And in low income and middle income households of India, unfortunately, the taking care of the ill comes on the, that entire burden is actually on the woman of the family. And taking care for someone who is ill is actually physically as well as mentally demanding. So like the patient, we always should actually have the caregiver also included in the loop. So now, coming to, let us say, we often end up starting dialysis for the patient. So there are two situations we are going to deal with. One is actually not giving dialysis to a patient, like opting for maximum conservative management. But unfortunately, that is much less common in our situation, and most often I believe that people refuse dialysis just because of financial commitments. They don't have the money to take up dialysis. It's not because of anything to do with the quality of life or anything. But most often they end up dialysis, and at the end of say 1 month or 2 months, find that things are not working out well. And then comes this question, doctor, whether I can actually stop this dialysis. So what situation you would stop dialysis? Jayalakshmi ma'am. If a patient comes to you, the same patient, let us assume the same patient was started on hemodialysis. He's not doing well at the end of 2 months. And he is asking, doctor, whether I can stop dialysis. What would be your answer?
Basically, when somebody wants to stop dialysis, if it is going to be for logistic reasons, they are unable to spend for it, and they are not unable to reach the place of dialysis, then that cannot be a reason for us to stop dialysis, because we should find a way out for a person who wants to have the proper treatment. For such patients, we generally don't stop dialysis, but we send them to a nearer setup. We can change over from HD to CAPD, and then we can take care of the logistics, and that will help them to continue dialysis. But we generally stop dialysis for patients who don't want dialysis because of multiple comorbidities. For example, the patient who had a fracture, every time they want to shift the patient to the hospital, it's very difficult for them to come and go. And the caregiver fatigue is there, where they're unable to take care of the patient. And the patient himself feels that he doesn't want any more dialysis. He just wants to be at home with a conservative management, living the rest of his life peacefully. Then that may be a sign for us to stop dialysis, involving everyone in the discussion, the caregiver, the patient, and the doctors. Everyone should get into the discussion, and then we can stop dialysis. So we should not stop dialysis for logistic reasons. We should not stop dialysis when a patient says, I feel depressed, I'm afraid. All these things need a lot of counseling, and we can go ahead with dialysis. But in an elderly person with multiple comorbidities, when shifting to dialysis is difficult, such patients, we can take the patient's interest, in the interest of the patient and with the wish of the patient. Or if the patient is going to be moribund, unconscious, then the caregiver or the legal agent will be able to give us an opinion or his idea about stopping the dialysis. If the person is the legal caregiver of the patient, we can take their idea, and then we can decide on whether to stop dialysis.
So basically, madam has covered almost everything. And another important thing which we need to consider is depression is very prevalent in elderly, and it might not manifest. The manifestations of depression might be pretty different from the younger people, because sometimes actually it's not uncommon for a patient, elderly patient who is relatively doing well on dialysis, coming to you one fine morning, I'm done with my life, I don't want to live. So rather than paying too much attention to that, you should always make an attempt to see whether it is actually his real wish or whether that wish is coming out of a depression. So do not hesitate from getting help from your psychiatric colleagues or clinical psychologists if the situation demands. So can you simply stop dialysis, Can you simply stop dialysis if the patient, you feel that the patient actually is moribund? Can you take that decision individually? Would you like to get somebody else involved in that decision making?
Yes. Generally, I would like to involve the other people, because I can get the help of my colleague who can also give me some inputs on whether we can do anything more for the patient. And we can get the extended family or a little more relatives to get into whether if they are able to give a psychological support or support the patient, then it might be possible to continue the dialysis.
Yeah.
So if it is not on medical grounds, it's on more of a social grounds, I would like to get an extended opinion on it.
We will deal with this because this actually stopping dialysis in a patient has legal implications. It is passive euthanasia. So in India actually the rules are slightly different. We will come to that. Basically it should be endorsed by somebody else also who is not going to be part of primary team. That is extremely important to avoid legal hassles in future. Now, let us say this patient, you have a CAPD patient in the terminal stages and the patient was doing exchanges himself or herself. And the patient clinical status has deteriorated so much. The patient is not able to carry out the exchanges and unfortunately all the children are employed. There is nobody in the family to take care of the dialysis session. How are you going to deal in that scenario?
If the patient who was actually performing CAPD by himself is unable to perform in its terminal stages, we have to think of a substitute who can actually help him to perform this, like a paid caregiver or a relative. But if none is available, we can also think of switching over to hemodialysis. But whenever we switch a CAPD patient to hemodialysis, it should be, the goal should be realistic. Like it should just be to prevent a fluid overload state. Say as and when required, you can dialyze him. But it should not be like to treat him thrice weekly or alternate day. It should be just to prevent a fluid overload, just to take care of his fluid loaded situation.
Yeah. So again, here the focus is basically on symptom relief. Now let us see what are the common symptoms which actually patients who has opted not to get dialyzed or patients who are being withdrawn from dialysis encounter. So nobody wants, pain is something which everybody is afraid of. Nobody wants a painful death and everybody would prefer to have a peaceful, calm death. Then there will be nausea, some confusion, agitation. Like these are all symptoms that comes as part and package of advanced kidney disease. Now let us see how are we going to, whatever be the situation, let us say maximum conservative management or withdrawal from dialysis, how are we going to manage the symptoms? So Dr. Shivaram, how will you manage the pain?
Pain is most bothersome complaint and most common complaint most of the end-stage patients will encounter. Mostly, even though death and suffering are certain, nobody want to discuss regarding death and suffering, any patient. As per Elizabeth Kubler-Ross, who she is authority on death, there are 5 stages. Once you tell any irreversible disease be revealed to the patient, the patient will go through 5 stages. Initially, denial and isolation, next anger, bargaining, and depression and acceptance. In every stage, we have to intervene and we have to give the support to the patient, even psychologically, pharmacologically, and also physically. And coming to pain management, there are 2 types of pain: nociceptive pain and neurological pain. Especially in diabetics, neurological pain is very, very bothersome. And according to WHO scale, pain scale, we have to go through. The same applies here in kidney disease also. We have to try non-steroidal, you have to try non-opioid analgesics like acetaminophen, most commonly used. You can go up to 3 grams per day, and we try to relieve symptoms. If it is not relieving with that, mild analgesics and mild opioids and severe opioids we can go through. And mild opioids, especially in end-stage renal disease, we should avoid morphine, codeine, and tramadol because their absorption is erratic, and patient will suddenly deteriorate because of erratic absorptions and all. And rest of all opioid analgesics, we can go in a systematic manner and try to alleviate his pain. And also psychological support and also physical, like physiotherapy and psychological support, all this we have to add. There should be multidisciplinary approach, not only pharmacological approach in pain management.
Yeah. So sometimes actually somebody just holding the hands and speaking to the patient, that might be sufficient for some. So if that is the demand, we should have a system to provide the same. So it's not just pharmacology alone, it's an overall psychological management of the patient that's important. And the next important complaint, like most of the patients will be really afraid of, is having breathlessness. So how are you going to deal with breathlessness and volume overload?
Breathlessness is a major thing to tackle actually in end-of-life care. Basically, the main problem is anxiety, which actually contributes to worsens the breathlessness. So oxygen should be provided, and conservative management like blowing fan over his face so he can get the feel of air into him. And the main thing which we have to actually deal is the relatives. Because they'll get anxious. Why this patient is having breathlessness? Madam, do something. Why don't you treat him? Why don't you dialyze him? So these things have to be dealt in a very calm manner, actually. Patients might even develop a chain stroke breathing, which might be the end. So relatives should be counseled. This is the way the patient is slowly will deteriorate and end. This should be well informed to the relatives. And apart from that, the patient suffering should be brought down with, as already mentioned, opioids. And if it is a respiratory secretions that is causing breathlessness, you should actually give frequent suctioning, glycopyrrolate. And to actually decrease anxiety, you can give tranquilizers, you can give quetiapine. All these are pharmacological measures. And if the patient is on CAPD, we can actually try to remove his volume by using icodextrin or high percentage of dextrose in the dialysate. So these are the ways you can actually deal with breathlessness. But it is a worst situation in which you are actually forced to dialyze the patient.
Yeah, basically the only thing is we should not allow someone to suffer because of breathlessness. If actually one dialysis is needed to relieve that breathlessness for a week, go for it. If actually one exchange of CAPD is sufficient to reduce the breathlessness, go for it. There are no hard and fast rules denying dialysis because the patient is actually the center stage and patient comfort is of utmost importance. And what are the, Dr. Shivaram, what are the other common symptoms that you might actually come across if the patient opts for conservative management?
Most commonly, nausea, vomiting, and anorexia, there are very common complaint, and rest are like itching and pains and hiccups, thirst. All these things can be conservatively managed with various medications like metoclopramide. Like some patients have agitation and in mood alterations, like then we can take psychiatrist's opinion and take benzodiazepines, haloperidol, all these things we can manage. Based on science, we have to think of side effects before treating all these patients and all.
So, now we have already discussed about this. This question we will actually take up a little bit later, maybe towards the end of the session, okay? So, one common complaint from patients is, most of the time we fail to talk to patients about the prognosis, and 90% of the patients are happy. This is actually data from the Western world, but I believe still actually this might hold in Indian setup also. 90% of the patients are ready to know the prognosis, and a good majority of them are ready to accept the prognosis even if it is actually the worst. So that was what I was telling before. There is no question of hiding from the patient. Please be open with the patient. Talking with the bystander is not sufficient because children generally will want their parents to live to the maximum possible extent. But whereas the parents' perspective is actually something different. They might not want to burden the children. So you have to keep in mind that each individual has the autonomy. My life is actually my choice and nobody else, whether it is my immediate, unless I am in a state not to take a decision, nobody has a stake over my life and it is my choices. And that actually applies to every single person sitting before you. Now, what are the legal barriers on withdrawal, or like we are coming to the topic of the passive euthanasia here. So, passive euthanasia is legal in India, but how we will go around that? This question is to Dr. Kiran Mai. Yeah, okay. So, basically, the Supreme Court of India has legalized passive euthanasia in the year 2018, and like a lot of work was going on in the early part of 2000, and everything actually started changing with the Aruna Schoenberg case, which actually you might have read in newspapers. So Aruna Schoenberg was a nurse in KEM hospital in Mumbai. She was assaulted and she was in a persistent vegetative state for 37 years, and the KEM college was taking care of her. And somehow, somewhere in the early part of the 2000, a journalist called Pinky Virani came to know about Aruna Schoenberg, and she had spent considerable time researching on her lives, and she has written a book called Aruna's Story. And 2011, she approached the Supreme Court asking for permission for euthanasia for Aruna Schoenberg. The Supreme Court that was actually a case which tilted everything in India. The Supreme Court realized the importance of not prolonging somebody's life in a persistent vegetative state. And the Supreme Court realized that this patient is actually beyond salvageability, but they didn't give a favorable judgment just because Pinky Virani was not considered as a friend. Aruna Shanbag was practically an orphan and she had no relatives, and in this situation KEM college was actually her friend and the KEM wanted her to leave. So her friend's decision was actually given importance and Pinky Virani's plea was actually rejected, but that was a case that actually paved for Supreme Court to frame rules on passive euthanasia. So the first ruling came in 2018, so that actually legalized living will. And it was a little bit strict, then you have to go to a district magistrate and you have to execute a will, and the will be kept in judicial custody till actually you reach a stage where you cannot take decisions. But now in 2024, another ruling has come. It has relatively simplified everything. You can make a will in the presence of a gazetted officer. And there will be 2 boards. And previously the medical boards has to be set up by the judicial authority. Now actually presently the situation gives freedom for the hospital to create 2 boards, and one is a primary board which takes care of the patient and a secondary board, and again it is not an individual. The number of physicians initially was 4 in each board, now actually it is 3. You have to set up 3 boards at hospital level, the primary board of 3 physicians, one including the treating physician and any other 2 physicians, and a secondary board comprising of 3 different physicians who are not going to be part of the team. And this board has to come to a conclusion within 48 hours. And active euthanasia is still not legal in India. Passive euthanasia means that you can actually stop all life-sustaining treatment. You can stop feeding to the patient, you can stop inotropes to the patient, you can stop giving oxygen to the patient. All are permissible provided it is approved by the primary and the secondary board. Now, is India ready for the concept of palliative care? What are the barriers ahead? Because Western system, and even though it is legalized, still I know many people might not be receptive. We will come to that, what actually we face in our day-to-day practice. So I would like Dr. Jayalakshmi and Dr. Kiran Mai to take up this question.
What is different? What are the barriers in order to provide this palliative care? I feel that the first and foremost is we, the nephrologists, as a nephrologist, we actually don't deal with or refrain from telling the prognosis to the patient himself. And actually we refrain from telling that the patient is dying, we refrain from dealing with the dying patient as well. That is the biggest, 30% of the population actually don't like or dislike in discussing these things. So we are not equipped in dealing with this sort of patients and discussing this sort of things actually. That is the biggest challenge, I think. And the another one is the support care. The persons who will provide the support care are scarce. They're not trained or properly trained to take care of such patients. So those patients are actually minimal. So in order to send such patients to a particular care is also lacking. The patient's ignorance of the patient also, even though you are not telling the patient is one thing, and even after telling the patient about the various cares available, the patient may not willing to go for this hospice care also. That is the biggest challenge we face.
So Jayalakshmi ma'am, would you like to add something?
Basically, even though the country as a whole may not be ready to accept the concept, but it's high time we bring the concept and popularize, because it needs some training. It needs a palliative care team to get trained, and the mindset of the students, the nurses, the caregivers, everyone has to be tuned to receive the palliative care. So it is high time we started the training of everyone in palliative care. And our main problem, our barrier is that any patient comes to us, we would like to treat the illness, treat the symptoms, make him better. But the main thing is to make the patient comfortable. So that should be borne in mind before we treat the patient.
Yeah. So basically, these are the usual barriers. And a very common situation which actually we face in India is nobody actually makes a living will. Even though living will is legal, nobody ever makes a living will. And probably what we often see is patient comes, patient deteriorates, patient is not in a state to take a decision. then there will be 5 or 6 children with 6 or 7 different opinions. Some of them would like to continue on dialysis, some of them would like to stop dialysis, some of them will be having some other fancy plans. And of course, that is actually a difficult situation which we face. The only thing is, there actually comes all these legal issues. If the patient is ready to take a decision consciously, willingly, fine, you are on the safer zone. But when actually there is children with differing opinions, then you have to actually check whatever guidelines are there in your state. And unfortunately, not many states have come up with this end-of-life care concept and all. The state of Kerala has certain guidelines on determining the futility of care. Similarly, state of Haryana has, and it might actually different. We have to keep in mind that health is a state subject, and it might actually vary from state to state. And you will have to check the rules, what is available. If it is there, you follow that. And if it is not there, please ask the hospital to set up a board, and it should not be your decision to deny dialysis. It should be decision vetted by independent specialists. And Maitri, I have the final question for you. What are the future steps in popularizing the concept of palliative care for CKD in India? I know this is to Jaimina and Dr. Shivram.
As already mentioned, the first thing what we should do is to add palliative care in the curriculum of undergraduation. So every doctor who exits should not alone plunge to action for saving a patient, but also they should be taught how a patient should die with dignity. That is the main thing. Apart from that, all the medical professionals should be taught on palliative care. Apart from that, there should be a societal change as such to actually accept palliative care. Palliative care doesn't mean denial of treatment. It means to help patients die with dignity. And it should be a quality marker in hospitals. So as NABH gives quality standards, end-of-life care should also be a quality standard for managing patients in terminal illness.
Yeah.
These are the changes, and social media, everything should be
We can take
highlighted.
Maitri's help for that.
Yeah.
We can actually ask her help to popularize the concept of palliative care in nephrology. And final question, that's to Maitri. What do you think, what are the relevant knowledge gaps in palliative care that needs to be addressed by future research? Because nothing is complete without research.
True, ma'am. Like you rightly mentioned, the short-term scoring systems that we have, short-term mortality scoring systems, they are purely based on data from European population and the American population. As such, we don't have studies from Indian population, the predictive scores, because all these scoring systems, they are derived from the registry. So they have a registry in Europe, they have registry in America. Only thing is we don't have a proper registry in India. Probably having a Indian registry would help very much in creating a predictive, mortality predictive scoring system for the Indian population who are on dialysis. And these scoring systems, because they are derived from the registry, they don't have all the components that are exactly required to increase the predictability of mortality. Like for example, we need to look into the comprehensive geriatric evaluation, the cognitive dysfunction, the psychological aspect of it, the nutritional aspect of it. So all those parameters are missing from these predictive scores. So that would be an area of research where we put in the comprehensive geriatric assessment as well to improve the predictability of these scoring systems. And there are many innovative devices now, like the artificial variable kidney, wherein we can use those artificial variable kidney for symptom management for patients who are at home and who want to take care of the volume overload symptoms and breathlessness. Maybe we could try those innovative devices in them.
Yeah, so then actually, like I would like we are running out of time, and actually we have not intentionally discussed palliative care in AKI. So basically it is again on the same rules. Most of the time we end up dialyzing the patient, and subsequently we realize that the patient is probably having a terminal illness that is going to kill him or her in a couple of weeks. So the general principles of denial of dialysis or not initiating dialysis in AKI also remains the same, and that is even a gray zone even in developed countries. And we have around 2 minutes left, and I would like to know what, because we have 5 persons representing 5 different states of India, so probably we'll get a perspective of how people, like have you ever discussed palliative care with anyone, and how receptive are patients to this idea of palliative care? This is basically just your personal experiences.
We in government hospitals, we usually discuss regarding this terminal care with the attendants. But as it is there is no finances involved, most of the patients will tell, go ahead and do dialysis.
Yeah, apart
even
from
if survive or
financial
not.
decisions, because that's the most
Rest of the
common
patients,
reason
then
of
they won't,
denial.
generally they will tell, try once or
Okay,
twice
okay.
and then decide.
So everybody
First
wants to
treat the-
have a
first
trial
treat
and
the
error.
patient and for some time, and if it is not responding, then they will decide. The patient attendants generally will tell,
Yeah,
most commonly.
Dr. Jaimina?
The thing is, in Kerala is different because people.
You will dialyze till grave, till the
they'll
coffin
be-
is laid.
They'll be dialyzed till grave. Even with multiple comorbidities, end-stage malignancy, it's very difficult to actually
Yeah, it's
convince.
very difficult to convince people.
the
Yeah, I
people.
also second that because I've been there for quite some time. And Jayalakshmi ma'am, I believe the situation in Chennai, especially in a government medical college, is different.
Yeah, actually in Tamil Nadu we have an extensive dialysis care being given, lot of centers being set up, and we have a CAPD being done extensively throughout the state. In spite of all this, I do see people who got to take care of elderly patients coming and asking us whether it's possible not to dialyze the patient and whether we can do something conservatively. Such
Yeah.
group of patients are there, and we tell these patients about the conservative management also.
Yeah,
also being
that's
done.
something which I have noticed after moving to Pondicherry from Kerala. There are so many people who are ready to accept the facts, and there are many people who are okay with the concept of palliative care. And Kiranmai ma'am, what's your experience?
Actually, I would like to tell one particular case where my son's classmate's grandmother, she was bought by her husband and actually daughter-in-law. Her creatinine was 8 for the past so many months when she came to me. And she simply refused to come into my chamber. They bought her with effort, cajoling and all. And she refused to enter my cabin also. I had to go by outside into the lounge and explain her about all the things which are offered once you are diagnosed as kidney disease. But she simply refused everything. She just
Died
chose the
peacefully.
conservative management.
Yeah. Maitri, quickly your experience.
It is mostly because of the caregiver burnout that I have noticed people going into
Okay.
palliative care or opting for palliative care in our setup.
Okay, not okay. Actually, the case which I presented, that was a close family member of mine. And we had a discussion. The only thing which he told me is, I do not want to end my life hooked to a machine. So we had an open discussion with the family members. They decided to go for maximum conservative management. He lived for around 16 months after taking that decision and died peacefully at night, probably because of hyperkalemia.